Island, where he has served as a neonatal research network investigator since 2010. He served on the advisory board of the Maternal Fetal Medicine Units Network of the NICHD and was vice chair of the Data Safety and Monitoring Board of the NICHD NRN. He has published numerous original papers, review articles, book chapters, and editorials, and present over 300 lectures at national and international conferences. Additionally, 50 workshops or roundtable discussions, and was visiting professor in over 20 medical institutions in the US and abroad. It's another pleasure for me to have you here, Professor. Thank you so much to give us the pleasure to have you here with us.
So thank you so very much for your wonderful hospitality. You have gone well above and beyond anything we could reasonably expect. So it's been a real pleasure being here. And I have to say, the only complaint that I have is making me follow the brilliant educator that Lucky Jane is, because that's a hard act to follow. No one can live up to that. And by the way, I apologize for the typo in the title. I think one of the things that keeps me going at the age of 70, despite all the frustrations that Lucky so nicely pointed out, is the opportunity to share knowledge with all of you and many, many others over the years, because it does add meaning to our work. I think you all do that as well to a significant degree in various ways. So there are things that do keep us from succumbing to the frustrations that we all talked about just a moment ago. So without further ado, I guess I have a lot of ground to cover. So we're going to talk about two things sequentially. The first talk is on non-invasive respiratory support. I prefer respiratory support to ventilation because things like CPAP don't actually ventilate, right? They provide support. But anyway, so here we are dealing with preterm infants, and the focus will be preterm infants who, of course, have all these challenges in maintaining and establishing functional residual capacity. And some form of non-invasive support benefits them from the beginning, and there's lots of good evidence to say that initiating non-invasive support immediately rather than waiting till the baby gets into trouble is important. That's why we don't typically these days see the classical picture of RDS on the x-rays, for example. It's become increasingly difficult to diagnose RDS because we don't let it happen. We don't allow babies to sit around and use up what's a fact that they have. So there's, of course, other things as well. They have immature respiratory control and they have central obstructive apnea. And non-invasive respiratory support addresses all of those needs. And of course, the prototype respiratory support has for many, many years been CPAP, which at one point was somewhat displaced by our enthusiasm for gadgets and mechanical ventilators. And now we're coming back to realizing that most babies actually do quite well without being ventilated, being intubated. So let's start with a theoretical, hypothetical. Actually, this is potentially a real case, and see what sorts of things we might learn from that. So this is a not unusual scenario, a 25-week, 690-gram white male, wimpy. We call them wimpy white males in the US. They tend to be more immature, you know that, right? Born by vaginal delivery after premature rupture of membranes, preterm labor, received antenatal steroids. UPGAR scores were 4, but responded well to non-invasive support, few inflations with a T-piece resuscitator. Now it's 5 minutes old. And on face mask CPAP with good heart rate, good respiratory effort, is retracting, however, has an oxygen requirement, but not terribly high, and has saturations 86%. That's good, right? For 5 minutes of life, it's good. We love it. So now, what would we do? We have lots of options. We don't have an audience response system here, so we're not going to make you vote, but you can think about it and mentally think to yourself, what would I choose for this particular baby? And the options are transfer the baby to the NICU and place on bubble CPAP. You can intubate, give surfactant, and rapidly extubate, the so-called INSURE approach. You can continue CPAP and give surfactant via this less invasive respiratory support, surfactant administration, giving it via a thin catheter while the baby remains on CPAP. You can intubate, you can give surfactant and continue on mechanical ventilation to not have to make the baby work so hard. He's a 25-weeker, 600 some grams. Or you can do the same, but put him on high frequency ventilation because you believe that that's preferable for very immature babies. You can start NIPPV or NIV, whatever you call it, non-invasive positive pressure ventilation. Or you can place the baby on high flow nasal cannula of 7 liters and watch. That's a lot of options. The funny thing is, some people, there are NICUs that will do every one of these things. There are individual neonatologists who would choose to do any one of those things. They're all not unreasonable. But which is the best? Well, evidence isn't entirely complete on this issue, but there are a fair number of studies, and I'll try to run through some of the available evidence going a bit quickly because of time. So why not intubate babies immediately in the delivery room, which is what we used to do until not that long ago. Right? There was a time where I think baby less than 1,000 grams, less than 27 weeks would be intubated automatically. But there are problems. There's a cost to interfering with the normal cardiopulmonary transition by ramming a laryngoscope down the baby's throat and inserting a tube. Once you intubate, you often generate excessively large tidal volume. In many places, they're still using self-inflating bags, which don't have the ability to effectively deliver positive end expiratory pressure. So that's a very injurious way of ventilating. Of course, there's the risk of hyperventilation, hyperoxia, which we often do. Not to mention that it's painful, it's invasive. Certainly intubation is an invasive procedure. It's stressful. It often leads to bradycardia, large surges in cerebral blood flow, blood pressure because of the pain and stress. And of course, we can injure the baby. People argue about whether or not we should give analgesia. So there are arguments, these are all arguments against automatic intubation. Of course, if a baby needs intubation and we fail to provide adequate support, there's also cost to that, right? So we have to have good clinical judgment to do what we need to do. So we used to think, you know, babies at 26, 27 weeks, of course, they lack surfactant. They need help. They need surfactant. It turns out that you don't need as much surfactant as a typical full-term baby has. And that has to do with, I think I'm going to peel this out because although I don't stroll around as much as Lucky, I don't like to stand behind the lectern. So, so yeah, you don't need as much surfactant. And surfactant's not an all or nothing thing. It's there. It's just there in limited amounts. If we, I'm sorry, if we, I always have frog in my throat in the morning. If we, that's okay. If we intubate and ventilate, we risk volutrauma, and volutrauma inactivates surfactant. There's some very nice data about that. Antenatal steroids actually nowadays will be giving almost to all preterm babies when opportunity is there, and that of course helps mature lung function. And by avoiding intubation, we avoid the risks of having an endotracheal tube, the foreign body that attracts infection. And it turns out, thank you, appreciate it. Don't know where I'm going to put it, but I'm going to wander around and I'm going to put it over here. It's all good. It's a it's a balancing act. All right. So so there's lots of reasons not to intubate, and it turns out, and there's plenty of evidence now that you can ventilate or support babies quite nicely without mechanical ventilation. We used to think that giving surfactant early was important. So there was a tendency to give prophylactic surfactant to all babies below a certain gestational age. I think some units still practice that. And this was based on evidence from randomized trials. And indeed, if you look at, whoops, what did I do? I didn't want to do that. I'm trying to figure out the pointer here. It's a big one. Okay. Does it work on here or on here? None of the above. Oh, you can see it. Oh, there it is. Okay. So there's a whole bunch of randomized trials, and you can see that in aggregate, indeed, there was benefit to early surfactant. But these were studies done in an era where the alternative to intubation and surfactant was to put the baby in an oxyhood and allow their lungs to collapse. And that's what then you had real RDS. And if you then intubated them with a delay and gave him surfactant, it was not as effective as when you gave it early. However, when you look at more recent data where the alternative to intubation and surfactant was early application of non-invasive respiratory support, mostly CPAP, now the results are different. And in fact, the trend is to benefit avoidance of intubation and surfactant. So we need to recognize, and in fact, putting it together does make sense, right? Because this is now what we do. And yes, there are not as many studies here, but the clinical evidence is now pretty dramatic and cumulative. So we no longer intubate automatically. CPAP, of course, doesn't work in all babies, and there's clearly a gestational age dependency. So this is a relatively recent study, an observational study by Peter Dargaville in Tasmania, who looked at outcomes by gestational age. And what this shows is, so these are babies who are immediately intubated. Okay, so below 29 weeks, about half the babies were intubated immediately, and more, almost 90% of 25 weekers were immediately intubated in the delivery room. Of those who attempted CPAP, where CPAP was attempted, the success rate was about 50%, about 50%. And then it gets bigger, then it gets better. These clear bars are successful application of CPAP, so 28 weeks, 29 weeks, etc. So mostly successful. Now, these results are not as good as what has been published out of Columbia Hospital in New York and similar institutions. But this is what they saw in Australia. But this gives you a pretty good idea about worldwide practice and the sort of success rate that might be seen. But there has been a school of thought, so to speak, the Columbia Hospital in New York folks and their followers, and there are now many and growing, have a remarkably low rate of bronchopulmonary dysplasia, and they attribute that to the use of bubble CPAP. And the question is it really magical? Is that the answer? Does it really work? Because they were excellent clinicians, but not great scientists in the sense that they never did a randomized controlled trial to convince others. They did observational study, they published their outcomes, but it has remained a somewhat unconvincing argument other than the apparent results. And so there are a bunch of small studies, mostly observational, not necessarily randomized, but in aggregate, they suggested a small benefit in terms of CPAP success rate of bubble CPAP compared to regular CPAP. So this diamond is to the left of the line of unity, suggesting benefit of bubble CPAP. There's a larger study done from in a middle-income country where bubble CPAP seemed clearly to give better results at various gestational ages in very small babies, not as many, because this was a developing country. didn't make a difference in the bigger babies. Both worked adequately, but so that was encouraging. And then finally, there's this large observational study where the two genes of bubble CPAP nowadays. Honey Ali from GW. Now he's moved somewhere, I think, to Case Western. Put together a large data set. It is still an observational study in the sense that these were their babies treated with bubble CPAP, very small babies over a long period of time. You can see between 2002 and 17, over almost 800 babies. Overall rate of BPD was incredibly low. They looked at a more recent epoch where it was just under 5%. And compared to the Vermont-Oxford network, which is a large database that's now become international, but it does include a large proportion of babies. So their survival rates actually were pretty good for even the tiniest babies. Very good for 500 to 750 grams, and babies alive free of BPD. These are pretty impressive numbers. So it appears that and there are a number of other smaller publications and less convincing, but so it appears overall that bubble CPAP does have some benefits overall. Among others, it is able to be delivered through a relatively inexpensive setup, right? You can do it with very limited resources. It doesn't require a special machine like these BiPAP devices, doesn't tie up a ventilator. So there are advantages, but it seems to work rather dramatically. There's also something that the folks in Seattle have tried, which is what they call high amplitude bubble CPAP or Seattle PAP. And what they discovered was that when you have a relatively large bore a piece of tubing over here, in this was actually a rigid thing, and if you make an angle to it and make the bubbles come out to the side, the amplitude was bigger. When you make it go up at 45 degrees, there was really high amplitude bubbling, and it appears to actually be able to be transmitted to the lungs and generate essentially some degree of oscillatory ventilation without a fancy oscillator. So there's good animal data that say this works really well. They're not convincing human data on this subject, but it's an interesting concept. But it's probably more than just bubble CPAP versus regular CPAP, because the other thing that the Columbia and their followers do is they keep their babies on for a longer period of time. In other words, most of the rest of us used to, because we've changed, I confess, used to, as soon as the baby didn't need CPAP by various oxygen requirement criteria, et cetera, they were taken off CPAP and just put in either high flow cannula or just room air. But we know that fetuses in utero will develop pulmonary hypoplasia when there is oligohydramnios, when there's a lack of distending pressure to their growing lungs, the lungs will not grow well. We know there's pulmonary hypoplasia in diaphragmatic hernia, but that can largely be reversed by plugging the trachea and applying increased distending pressure. So many years ago, this is not a novel concept. People demonstrated that by exposing ferrets, in this case, to distending pressure postnatally, they were able to increase lung volume, lung weight, and it wasn't just fluid retention, it wasn't just edema, it wasn't just stretching of the lungs, there was increased protein and DNA, so this was real growth. So these are old data. There are some more recent data that suggest that this is real, and we know that postnatally, we can make lungs grow by applying distending pressure from other experimental studies. And I used to always use high distending pressure in my ECMO babies when I was doing ECMO. And here is a study that was published just a couple of years ago. from Cindy McAvoy's group, where she randomized babies who were ready to come off CPAP by clinical criteria to come off CPAP as usual. That was the blue curve, or to remain on CPAP for another 2 weeks. And what she demonstrated was that there was increased, you see that? There was increased FRC, so suggesting lung growth at the 2-week point, and that seemed to continue so that at the time of discharge, there was quite a dramatic increase in functional residual capacity, suggesting that the lungs indeed did grow better. And it may well be this fact that accounts for the very low incidence of chronic lung disease in babies who are treated with bubble CPAP for a longer period of time. I think it's a longer period of time. In fact, that may be the important thing, but it's a package deal and it seems to work. And we started doing it now, I confess. Is the evidence 100%? No. There is a randomized trial underway now to make to confirm that indeed continuation of bubble CPAP until at least 32, 33 weeks reduces the rate of BPD. That study should have been done 25 years ago, but it's finally getting done. All right, so there's other kinds of non-invasive respiratory support. I'm going to briefly talk about some of them. So there's this, this high flow nasal cannula, which seems to have similar efficacy in larger preterm infants, but not as good in the less than 28-week babies. It does deliver some distending pressure, but largely seems to work by upper airway washout. There is things that are called NIPPV, non-invasive positive pressure ventilation, or non-invasive ventilation, NIV, which is typically not synchronized. At least in the US, we don't have any approved way of synchronizing it, other than, turns out, NAVA or BiPAP, similar. They do not generate a tidal volume. People mistakenly believe that these things actually ventilate. It's been shown that they do not. They are typically, there are studies that show that NIPV was better than CPAP, but it was always because the mean airway pressure was higher. It was apples and oranges comparisons. When the mean airway pressure was equal, there was no difference. So it's a stealth way of increasing mean airway pressure. People are playing with nasal high frequency oscillatory ventilation. It's not yet, it's I think still experimental, but there are places that do that clinically. And then there is non-invasive NAVA, neurally adjusted ventilatory assist, NAVA, done non-invasively. It is probably the best form of non-invasive ventilation because it does synchronize. And that turns out to be important. It turns out that in preemies, the glottis, the vocal cords, are closed unless the baby is actively breathing in. And so if you don't synchronize, majority of inflations will not result in a tidal volume. So very briefly summarize some of the evidence that's out there. So we have comparison between high flow cannula and CPAP. There was a large US trial done by Bradley Yoder. Babies for at least 28 weeks, both first line treatment and after extubation, about 400 babies. And he found no significant difference in treatment failure or need for intubation. So if high flow cannula is as good as CPAP, it's easier to use. The parents like it better. So, okay, that's maybe that's a good thing. Then there's a series of trials out of Australia. The first one by Brett Manley was the hyperspace trial. Babies less than 32 weeks were stratified by gestational age. 300 of them. This was always done. This was only after extubation. And in this cohort, failure rate was actually higher with high flow cannula. These are the percentage, but they had a generous non-inferiority margin. This was a non-inferiority trial design. And at high gestational age, it was clearly the failure rate was higher. So this was very iffy, but it seemed it was not quite as good. The hipster trial published in 2016, babies at least 28 weeks, first-line treatment, over 500 babies. The trial was stopped early because high flow nasal cannula had a higher failure rate, about twice as high. But most babies were able to be rescued with CPAP, so they didn't end up being intubated. But since success was the primary outcome, the trial was stopped early. So in this case, it seemed to be inferior. And then there's a most recent trial, was the Hunter trial by Brett Manley again. And this was a trial of trying to see if keeping babies on high flow cannula in community hospitals, these were not tertiary centers. The idea was, can you keep babies in the community, avoid the need for transport and separating the mother from the baby by using high flow nasal cannula instead of transferring them and putting them on CPAP. But it turned out that high flow cannula was not non-inferior, double negative. In other words, it was inferior to CPAP. So mixed bag. In the bigger babies, it seems to be okay, but it's reasonable as a first line treatment because you can always bail them out with CPAP and no harm done, perhaps. So that seems a reasonable alternative. I just want to explain about NIV-NAVA for anyone who's not familiar with it. So this concept here is that ignore the endotracheal tube because we're talking about non-invasive, so this would be attached to the nasal prongs, but the triggering occurs by an array of electrodes on a specialized feeding tube connected to the ventilator. And so when the baby's phrenic nerve signal triggers diaphragmatic movement, this triggers the ventilator to generate an inflation. So perfect synchrony, no trigger delay. It's a beautiful way of synchronizing non-invasive or invasive. I don't like it for invasive. I talk about that in the workshop because it's a positive pressure, it's a positive feedback, so it can overventilate and generate excessively large tidal volumes. But for non-invasive, it's probably a good thing. If you have the device, I would use it for non-invasive. If you think you need to do more than CPAP, that would probably work. Oops, all right. So lots of enthusiasts for NIPI. I mentioned before, there are studies, there's meta-analyses that show that it is better in certain ways and fewer babies met failure criteria, less need for intubation, decreased work of breathing. Okay, great, but this was always an apples and oranges comparison. There are also studies showing that maybe for primary mode, these were after extubation, as a primary mode, there might also be benefit. But again, those studies were done at unequal mean airway pressures. Then Harish Kirpalani went and did a large pragmatic multi-center trial of any device that you use to deliver some sort of cyclic positive pressure. So it was a combination of BiPAP and an IPPV. And primary outcome was an ambitious reduction in BPD or death combined outcome because they're competing outcomes at 36 weeks. So the traditional, what's considered most important outcome. There was 36 sites, over 1,000 babies. The key baseline characteristics were quite well balanced. These were pretty small babies, 800 grams, and most of them had received antenatal steroids. But the outcome was disappointing. There was no difference. The the odds ratio was very close to 1 with the wide range clearly crosses the p-value was nothing. And so that did not suggest that there was benefit to NIPV over CPAP. There were a lot of critics that complain about this or that, but this was by far the largest study. The problem, as I said before, is twofold. One was that most of the studies done abroad used synchronized NIPPV, which is not available in the US. And so maybe it's available to you, but it's not available to us. But most important, the level of distending pressure was very much higher in the NIPV group. So it was CPAP of 5 versus NIPV of 20 over 5 with a rate of 30. So the mean airway pressure was often almost 50% higher. And so the question of, okay, but maybe we can ventilate the baby. The baby's having apnea, so let's put him on NIPV and that'll keep us from having to intubate him. Well, Louise Owen from Australia did a bunch of studies. This is just one of them. And what she's showing here is that here's the machine cycling happily. But so the Grace-P capsule detects abdominal motion. There is no respiratory effort on the baby. This is respiratory inductive plethysmography, same thing. There's no respiratory effort. There's no tidal volume being generated, none at all, okay, for the duration of the apnea. And of course, the saturations are falling. So the ventilator is cycling happily up here, but it's not delivering any tidal volume. And here's, it does occasionally when by chance the baby breathes at the same time as the ventilator triggers. But this is the, it didn't matter what the pressure was, a very small proportion of respiratory cycles actually resulted in a tidal volume. So then, okay, maybe synchronized ventilation, non-invasive ventilation will work better because, well, it's synchronized. But of course, it's synchronized with what? It's synchronized with baby's spontaneous respiratory effort. If the baby's not breathing, nothing really changes. So here we are. It's not triggering because baby's not breathing, so there's no tidal volume. So maybe that's not going to work either. And there's another study out of Holland that looked at 2 different ways of measuring tidal volume. Keep pushing that button. Electrical impedance tomography on the left axis, left y-axis, and respiratory inductive plethysmography. Bottom line, CPAP or BiPAP, there was no tidal volume, no difference. So very disappointing, but people still believe in it. And I still can't get my colleagues to stop using NIPV and tying up a ventilator and dirtying up a ventilator, wasting a ventilator circuit because they say it works. But yes, it does work actually. I'm not saying NIPV doesn't work. It just doesn't work the way people think it works. It works because it's a stealth way of increasing the level of CPAP or mean airway pressure. And it turns out that that is important. Higher CPAP is often needed. So this kind of falls into this PEEPophobia concept of mine. Most of the world is afraid to use higher levels of PEEP or CPAP. And so they say, well, I'm already up on CPAP of 6 or 7. I can't go any higher, so I'll put him on NIPV with a pressure of 25 and a rate of 35. And but my CPAP's only 6. But your mean airway pressure is 11. But it works. So, there is the matter, the level of CPAP matters. And this is just an example of a particular baby. And you can see that oxygenation wasn't very good on low level of CPAP. And as CPAP was progressively increased, oxygenation improved until a certain point, and then actually did decline a little bit, although probably not significantly. CO2 is coming down. Okay, so CPAP doesn't ventilate, right? But it improves lung aeration, and that improves lung compliance, so the baby's respiratory effort becomes more efficient. So this concept that NIPV ventilates, it's not actually ventilating, but it's allowing the baby to ventilate more effectively because it optimizes lung inflation. So again, if you go too high, then things, of course, don't work out so well. So this is an important study done by someone from Eduardo Bancalari's group. And Eduardo used to be a famous PEEPophobic. I always was having little scrimmages with him at meetings because he was like, oh, CPAP of 5, that's all. And so to their credit, they actually did this study that I was suggesting that they really need to do. And they compared after extubation, their traditional PEEP of 4 to 6 to a higher level of PEEP of somewhere between 7 and 9. And lo and behold, babies on the lower PEEP more often met failure criteria, more often needed to be reintubated, whether you looked at 96 hours or 7 days. And so level of CPAP matters. And NIPV is a stealth way of increasing that, but you don't need to tie up a ventilator and waste a ventilator circuit. You just need to turn up your bubble CPAP or whatever CPAP you're using, and you're all good. So there were several studies that compared CPAP and in this case BiPAP or CPAP at the same mean airway pressure. So a few people recognize that maybe that's important. And lo and behold, there was no real difference in terms of gas exchange. So heart rate, oxygen saturation, CO2, no difference whatsoever. Respiratory rate, no difference whatsoever. Interestingly, yeah, so there was some very small differences, not clinically significant in terms of blood pressure. Another large study published in 2016 compared BiPAP at CPAP at equal mean airway pressure. It was unblinded for obvious reasons, but large study, 540 preemies, less than 30 weeks. And it was CPAP of 6 centimeters versus BiPAP with a delta P of 4, but mean airway pressure of 6, so same mean airway pressure. And there was absolutely, again, no difference in failure rate, the primary outcome, or any other outcome for that matter. So, a few studies comparing NIPV and BiPAP, because one of the criticisms for Harish Kirpalani's study was that a lot of babies were being treated with BiPAP rather than NIPV, and the aficionados of NIPV said, BiPAP's not good enough because the delta P is not enough. So the bottom line is really not really, and I think we're getting short of time, so I'm not going to spend the time going through all of these. So synchronization might be helpful, as I said. There are some synchronized studies that seem to be better, but again, it was using a higher mean airway pressure. And so NIV-NAVA might work better, but there are no current studies that give us a clear answer here. Thank you for that water. All right, so actually one of my fellows a few years ago decided to look at this, comparing NIPV and CPAP at equal mean airway pressure. And we argued that what I just said, that NIPV is but the stealth way of increasing mean airway pressure, and that when compared to the same mean airway pressure, NIPV and CPAP will give a similar level of support. So this is a small but crossover study. It's a bunch of physiologic measurements. So, your typical non-invasive support babies, gestational age 27 weeks, less than a kilo. They were done. This was almost all post-extubation, so they were bigger by then, and they were needing relatively high descending pressure because now they had some degree of BPD. But so for 12 hours they were on this, 12 hours, and the next 12 hours on the other randomly assigned sequence. And what you see is basically absolutely no difference, whether you looked at transcutaneous CO2, oxygen saturations, percent time with saturations below target, mean airway pressure by design was equal. And so, we're not PEEP-phobic. FiO2, actually, the only difference was here, and it favored CPAP. And no difference in respiratory rate, no difference in bradycardia events or desaturation events. So, but there's one problem, and that one problem is that not all interfaces were created equal. And what we were doing was using a interface that's probably not optimal. And we're redoing this study now using a different interface. But here's the point. The RAM cannula took the world by storm because it was so easy to use. Do any of you use the RAM cannula or even know what it is? Do not use it? You're happy people. You're smart people. So this RAM cannula, I'll show you what it looks like, but it has really high resistance, and you can see that here. Compared to short binasal prongs, the resistance is like 4 times or more greater. And so this is this RAM cannula. approved as a high flow cannula, but it's been heavily marketed by Dr. Ramanathan, who fails to disclose his conflict of interest as a CPAP device. So it's stuck in the baby's nose, but they're careful to tell you you should not totally occlude the nares here. But so this is where it attaches to the ventilator circuit, and this long segment of tubing. There's no expiratory limb, so it's a one-way flow. It really works like high flow cannula. And this is the point here. So with the CPAP circuit, inspiratory limb, prongs, expiratory limb. With the RAM cannula, it's all just flow one way. And so you can't get a tight seal, because if you got a tight seal, you'd blow up the baby. So it's not a real efficient way. And the pressure transmission through the RAM cannula is really poor. So I don't need to waste my time, because people don't use it. So continue to not use it. And if somebody tries to get you to switch, please don't, because it's a really bad interface. And this is the most recent study that shows that it doesn't, the ventilator trying to generate a tidal volume is really almost non-existent. And so to sum up, non-invasive respiratory support is effective in most babies at greater than 26 weeks, and in really experienced hands, even 25 and 26-week babies can do quite well on that, and we are now down to those ages. Nasal CPAP remains a standard against which other devices are compared. There is pretty good evidence that non-invasive support can lower the rate of BPD. In larger infants, high flow cannula may be similarly effective. CPAP is as good as NIPPV when used at the same mean airway pressure. I think it's going to be the same whether or not, whatever the interface is. Synchronization may be helpful. There's a large multi-center trial underway of non-invasive NAVA. So we'll see if that pans out. But the interface that you use has an important impact, on effectiveness. So this is when your research funds run out. This is what you do. And that's all. So we're going to have questions at the end. So I'm sure I raised a lot of